to shift to our next amazing speaker. Mark Jarrett was one of the 21 of us on the 405C Congressional Task Force on Healthcare Industry Cybersecurity, and one of my favorite ones that was like a true public servant. Comes from a medical background and Northwell Health, but also is the head of the HPH Sector Coordinating Council, and in government speak, each one of those 16 columns I drew, the gray ugly mess, has a custodian in the federal government called, in this case, HHS, and a single sector coordinating council. And ours is an all hazards one called the HPH Sector Coordinating Council. A lot of you that do cyber deal with one of the pieces of this, but it's a much bigger kettle of fish, and really honored to have Mark Jarrett come speak to us. Welcome, Mark. Clap. Thank you.
So I'm going to try and go over some things. First of all, I want to thank Nate for his great talk, and I will say he is one of the few people that actually talks about what happened. I'm going to get to that towards the end of my talk, and that is critical if we're going to improve things, because you can't learn unless, history repeats itself unless you learn what happened in the past. So people like Nate who do get out and talk, it is really fantastic. So, there we go. Oops, that went too much. Okay. So first, who the heck am I? Josh told me how he knows me. He's saying, what's this gray hair guy with a suit and a tie talking about cyber? It's kind of like a little out of sorts. But I'm a recovering rheumatologist. I'm a physician. I was the only physician on the healthcare task force,
Yes.
which was an interesting, and there were a couple of nurses as well, so there were other providers, but I was the only physician. And I would say my bottom line, as Nate said, what do you want to walk away from this, is remember that cybersecurity is a patient safety issue, a patient safety concern. It's about patient care, all right? IT is a wonderful tool, but is it no different than any other tool we use, anything from an IV bag to a pump, all right, to our stethoscopes. And it's all about the patients. And that's always been my attitude in practice and in what I do now when I was Chief Quality Officer at Northwell for quite a number of years, and now working with them on other things. It was kind of COVID blew me out, much like Nate, except for more than 4 months. I was living in a room kind of running the COVID response for Northwell, and we had 21 hospitals and 800 ambulatory sites, 90,000 employees. Let's just say it wasn't the easiest thing in the world. So I kind of shifted gears, but that allowed me to now work with the healthcare sector in a much more intense way than I did before. So that is my underlying thing. Number two, I want to bring out another point from my quality perspective. And I always like telling stories. So, we talk about checklists, and checklists serve a function. So back at one of my hospital positions in the past, but overseeing quality for that hospital as well, a wrong-sided surgery occurred. All right, terrible thing. Patient did okay. It was a hip fracture. They put in the wrong hip. They recognized it. They put in the right hip. The doctor was upfront about it. Everybody. But they did their timeout. All know the tool going, well, you got to do this timeout, the patient's name, the procedure point. Everything was checked off. All the boxes were checked off. We responded by actually putting, because we felt that this was such an urgent thing to not allow to happen again, we actually put staff during every timeout in all the rooms. And what do we find, lo and behold? Even though all the boxes have been checked off, we were probably running about a 20 to 30% success rate of the timeout being done properly. Either people didn't really do the things, or they kind of did it, not looking at the patient, pointing at which side they're supposed to be doing, initialing things. We then took technology and we actually put video cameras in the rooms during the timeouts, which were live and being monitored, and then report back to the nurse manager for the OR if somebody didn't do the timeout right. They stopped, they wouldn't let the procedure go ahead, they called into the OR, and they had to repeat it. Doing that, our timeouts were really 100%. So I would just always caution everybody from the quality, speaking from the quality world, checklists look great, and it means these are the things you should be doing. But people check a lot of boxes and never do them. So we can't totally depend on that. We have to figure other ways to audit to make sure that what's going on is really what's going on. All right. So I'm going to talk about some other things now. First about the healthcare sector, and then go into the all hazards approach. So I always like quotes also. I like this one from Ralph Waldo Emerson back in 1860, the first wealth is health. And then Sir Winston Churchill said, healthy citizens are the great asset any country can have. And we all know it. You know, it's the old expression, if you don't have your health, you don't have anything. It is our obligation to protect the public health. And we certainly learned this during COVID, all right? It is really critical that we think in those terms. So the Healthcare and Public Health Sector Coordinating Council, which is, I use the initials, has this mission statement, and I'm not going to read the whole mission statement, but basically, as Josh said, we offer the critical infrastructure of healthcare. We are the private side of it, and then there's a government side of it. So last week I was just in Washington for our 3-day meeting. We had joint meetings with the government side. We went over our strategies. At the government side is HHS, DHS, FDA, CISA, ASPR, a whole host of people involved in healthcare, which is really critical. And we talk together, trying to see what we can do to improve public health in general. So a little snippet of something we did last year is, and until the beginning of this year, is we developed a critical medical device list, all right? So the FDA wanted to know, because the government wanted to know, what devices that if all of a sudden our supply chain went away, do we need to take care of patients that without, patients are gonna die, all right? And, you know, I don't have to tell you, there's a million different things, but the FDA put together a list. But they needed the private sector, which a bunch of us sat on, to vet that list. Because sometimes they put things down that to them sounded logical. You need EKG machines. And we all agree you need EKG machines, but we informed them there are probably 10 million in the United States. If you stopped getting them, it would probably take you 15 years before you ran out of them. So there were things that shouldn't be on that list, and we waste time thinking about how we're going to manufacture them, but then there were other things that were very critical. So that's where this public-private partnership works well together, all right? As well as the government coming up with information that says, you guys in the private sector have to help us figure it out, and we'll talk about that a little later. So I'm gonna put up a very complicated slide, which Bo tried to clean up a little bit, but talk about the structure of this. So first of all, everybody participates in this, does this on their own time. This is an unpaid thing. There are no donations by the organizations. We're not allowed to do lobbying. There's all kinds of rules that allow us to discuss things, so to speak, in private, so we can have honest discussions amongst ourselves. So we have an executive committee, and we kind of revamped this, and now we have what we call functional areas. And one of the reasons is healthcare, like everything else, is always stuck with silos, all right? And people have silos, this is what we do. And we want them functional where there's cross discussions, and we'll talk about cross-sector in a moment, because when we work in silos, we get into trouble. My favorite expression I always say is, silos belong on farms, no place else, all right? So we have an area which is clinical, which includes acute care and EMS and public health, mass fatalities. We have the infrastructure area, which includes IT, comms, cybersecurity, and that is actually where the cyber working group reports up to. All right, we'll talk about that in a few minutes. We have the support area, such as manufacturing. We have large pharmaceutical companies that are there. Blood supply, and we get reports every month about where the blood supply is, and as you know, there's a national shortage right now. The administrative area, and that includes academia, research, which is really in development, obviously, and the payers. And as we'll talk in a few moments about Change Health, the payers are critical to this, all right? So we can't kind of separate them out and just say they're by themselves. And then we have coordination, like incident management systems, healthcare coalitions, response support people, such as organizations such as Healthcare Ready. So all those together, And then we added a post officers council. So I'm chairing it, this is my second year. Next year I become the immediate past president, and the last couple of past presidents, and we all get together and kind of add our legacy of what went on. And the goal is that we all meet together, each has an officer and a deputy officer from different organizations, and we're now filling out some of these subsector areas as well, so we can all talk together about this. And this is an all hazards approach. Everything has to be considered. And I agree with Nate, cybersecurity is a major, major hazard, and therefore is one of the ones that we worry about a lot. And they have actually been very much, the cyber working group, out in the forefront. But it has to be taken in context that we have to worry about everything else. So we have standing working groups, one of which is actually going to stand down now, but we have ones on incident management, the cybersecurity working group, as I said, one on recovery and resilience, supply chain, one on exercise. We have these different working groups that all work together. They're joint working groups that consist of private people and the government people from the different organizations of the government. And we sit down and try and come up with things that make sense. And those of you in the private world know that you just don't want to get a 50-page document that says this is what you got to do. And again, getting back to the quality issue, part of getting that done is having an explanation why it needs to be done. People want to do things and will follow regulations or rules or policies if you say why. If you just tell them you got to do this, people listen, and it goes in one ear out the other. So we have this kind of complicated structure, but it's really kind of simple. We have right now in the overall group about 450 organizations, and more are coming in. In the cyber working group, there's which has to be integrated in a little bit more with some of their membership. There's another 400, of which 200 or 250 already belong, and they may have people who were in the cyber part, but maybe we want them for the all hazards part as well. So we work together on this because we can't work separately. If we work as silos, nothing gets done. If we work as silos, quite frankly, the government doesn't listen. They need to hear a unified voice that says we as a large organization, which includes major health systems from Kaiser, HCA, Intermountain, et cetera, all the way down, as we'll say, talk about small and rural areas, they have to understand that we represent really healthcare in the United States, all right? And that's where the healthcare is delivered. I mean, we have the VA system, there's federal qualified health centers, there's other government-run things, but most healthcare is private, all right? And we need, therefore, to have it, to have them understand why this is necessary and why we do this. All right, so our all-hazard approach, we have natural and man-made disasters. Obviously, a man-made disaster is what happened to the University of Vermont, but we have other man-made disasters, like the Boston Marathon, all right? We have natural disasters, yes, hurricanes, which are going to be very bad this year, potentially, earthquakes, wildfires, all kinds of things go on. And, you had what happened in East Palestine with the railroad derailment. There are lots of things that go on, and we have to be prepared for all of them, but they're all interconnected, all right? So we're dependent on other sectors. New York was hit hard by Superstorm Sandy, and Long Island, where we have a lot of our hospitals in Northwell, was hit very hard. Now, unlike Florida, which has a rule that all gas stations have to have a generator, none of the gas stations in New York had a generator. Nobody had ever put one in. So when there was a gas supply shortage, first of all, but there was still gas in all those big tanks they have underground, nobody can get gas from them because there was no way. You need electricity to pump them up. So there was nothing you can do. So for us at Northwell, we had a problem because most of our employees come by car. And after a day or two or three, they may not have enough gas in their car to get to work. Well, how are we going to get nurses? How are we going to get lab technicians? How are we going to get anybody? Where are we going to get gas for our ambulances if they're running back and forth all the time? So that was a problem. Now, our CEO kind of thinks out of the box a lot. So he found a gas station that was kind of in the middle of Long Island, and he bought it. and put one of our generators there. And if you showed up with your ID badge, your gas tank got filled for nothing. So people were very happy to come to work. But that's a situation where had nothing to do theoretically with cyber, and we'll get to talk about other things with cyber, with water supply and stuff, had nothing to do with cyber, but yet at the same time, and nothing to do really directly with healthcare, but this had a big impact on healthcare. And this is why we need an all hazards and very, very cross-sector type of look at how we protect ourselves, all right? Climate change. I mean, healthcare actually is a big producer of, of non-green stuff. We really, use a lot of electricity and put a lot of stuff out. That's getting better. Most hospitals sign these these things for climate change. But we know climate change is happening anyway. Without getting into politics, who's responsible? Climate's change. We all know that. But it has an effect on public health. We're now seeing malaria and dengue fever in Florida and other southern states. So we have to be prepared for all these things on all hazard. What about the next pandemic? Well, we're all worried about the avian flu, all right? It's a real concern. So how are we going to handle that? Cyber threats, I don't have to tell this audience, you all know the cyber threats. And quite frankly, we have a digital dependence. Are we able to work on paper long term for months? Obviously, University of Vermont managed it, Common Spirit managed it, Scripps managed it, but we have to be prepared to do it. And we have to be prepared to realize that the workforce has no idea how to work on paper, okay? When Superstorm Sandy hit, the physicians from NYU, most of them came up to Lenox Hill, one of our hospitals, because they had closed NYU and they put their patients there and all that. Our electronic record was down and they weren't sure how to use it and all that. And their biggest problem was they didn't know how to write admitting orders if they were under 40 or 45 years old, because they'd never written them. They had always just checked off boxes on the screen. And they could not think of, well, I have to do this, I have to do this, I have to do this. Writing medicine orders. They weren't, everything was pre-populated with all kinds of, warnings and stuff. Now they had to do it from memory. So we really, as part of our analytics, not only have the paper, we have to train people how to do things on paper. And then, as Extension learned now with their thing, how do you get that back into the EHR? When this all gets solved, if you have a large outage and it goes on for a long time, it's not a day or two. You can't pay people, you can spend it to put 3 months worth of data in the EHR. So now they have to scan stuff in, make sure it's available. So you have to figure this all out in advance, all right? So that's really important. And finally, again about this cross-sector, it doesn't have to be one event at a time. We all know the horrible thing that happened in Paris when like 90 people were killed, shot at the terrorist act in the theater. But interestingly, not a single person who was wounded and then got taken to the hospital, didn't die on the site, died. Paris, let me tell you, the French system really worked well in terms of trauma. They had hundreds of people and nobody died. But now what happens if the bad actors who did terrorists at the same time did a denial of service or distributed denial of service and knocked out the internet, the phones, the computers, couldn't look at things, couldn't communicate? Do you think there would have been 0 fatalities? No. A lot of people would have died. So again, this is why an all hazards approach has to be taken. We have to think about the fact that you can have a cyber event and then somebody takes advantage of that with a physical event, or vice versa. Back in November, the healthcare sector, we did a tabletop. We actually did a tabletop on a cyber issue going on and then a wildfire in an area that affected the hospitals, all right? No one, and therefore all the hospitals got knocked out of the thing that were taking some of the load from the hospitals that were connected, had the cyber thing that was discussed before. So we have to think of this all hazards approach to really get, to really attack this the right way and defend ourselves. All right. So also here, Volt Typhoon, you know that. I mean, you guys are more expert on this than I am.
Not the whole room.
No, not the whole room. So this was put out there, and it lives off the land. It kind of sits there. I'll tell everybody, there's a great book to read if you like novels, especially It's called Ghost Fleet. All right? It is a great, first you read Age of Danger and get really scared, then you read Ghost Fleet. And basically the issue is putting stuff in advance, as was mentioned before, so that if a nation state wants to leverage it when we're having problems, with them, let's say, example would be Chinese, trying to blockade Taiwan or doing something like that. Well, you know what? Knock out the water supply for a little while. Well, what happens to the water supply if, to hospitals? Well, you don't have any drinking water. All right, we got these. We can always pull these out, although you can't get that many of them eventually. But you can't flush the toilets. All right? It's a real problem in hospitals. It's a real problem at home. And you can't do a lot of the sterilization stuff. You can't wash your hands well. Using the gels are helpful, but if your hands really get contaminated, you got to use soap and water, because you can't get them clean enough with the gels. So there are real issues for hospitals. All right? And then there's real issues for the public. There was no water supply in New York. Where are you going to get enough bottles of water like this? Just not going to get them. Again, sanitation, toilets, things like that. And what are you going to get as a result of this? Panic. All right? And that's, remember, the ultimate goal of terrorism is panic. It's not always the number of people that die. It's getting people to panic. So we have to think in terms of these cyber events occurring, and they may occur later on tagged to another event. Again, cross-sector. Can't think just one thing or the other. Don't get to a silo. All right. Now, why is healthcare different? We're a mosaic, was said before. We're large, medium, small places, rural. We're going to use rural as an example. Healthcare is changing. More than 50% of healthcare now is delivered. The cost of healthcare is ambulatory. Most of healthcare is delivered in the ambulatory setting. All right, and now moving towards hospital at home, where we have all these remote monitoring systems, and we're putting patients actually back in their house, where normally they'd be in the hospital, getting care. All right, things have really shifted. On the ambulatory front, it was a real problem. For example, during COVID, because we closed offices, and all of a sudden there was a lot of, not only can ambulances be delayed, but it was the issue that people were not able to get their routine care, and we started cutting back because we took staff from the ambulatory, like ambulatory surgery centers, and moved them to the hospitals because we needed more staff. Because I remember on April 5th we had 800 patients on respirators from COVID in Northwood. It's a lot of people to take care of who were deathly ill. So we moved the staff over. But then you need a different standard of care. So you say, all right, the person who needs a hip replacement, they can wait a couple of months, they'll be miserable. But what do you do with a 40-year-old woman who finds a breast mass? Do you say, you're going to wait 2 months to get that removed? How do you handle that? So these are the things that complicate everything you have to think about. So let's just talk about rural, for example. I know Josh showed a slide on it, and I have the same slide. So just reminding you that rural areas make up 80% of the land mass in the United States. We're mostly rural. The flyover area, that's all rural. All right? But it's only 17% of the population. All right? But it provides most of the food, most of the energy, the fuel, all the stuff that makes the country go. All right? So we can't forget about the rural areas. All right? And they've had, a real problem, especially recently, getting, getting the funding and staying alive. And this is the slide of the rural hospital closures. I didn't animate as much, but you can see the numbers going up, and they're going to continue to go up. This is a real problem, and it's not solvable just with money. Unfortunately, money helps. But there are other issues that we'll talk about in a second that go with it. And this is the number of hospitals that are now considered to be vulnerable to closure, another 453. A lot of them are in states where they did not do the Medicaid expansion, but it's in other states as well. So this is a real problem, because if if people can't get health care in certain areas, they're not gonna stay in those areas. So who's gonna run the farms? Who's gonna work in an area producing the things that we need produced, all right? So what's the problem? They have, and this gets to, the fact that this all predates COVID-19. So it's not just the result of COVID-19. As Josh said, it's not just the result that there's cyber attacks. It's one thing layering on another. One thing is their workforce shortages, all right? In the big cities, we have enough trouble getting nurses and other highly qualified people for our hospitals. If you're out in a rural area, people don't want to stay there. Young people want to go to the big city and have fun. And certainly, if they're not going to get the right health care there, the families don't want to stay there, all right? They've always been in scattered populations. Said before, you hear at GW, if something happened to GW, you got Georgetown, a 10-minute ambulance ride away. Yes, it's more risk having to go further, but it's 10 minutes away. In rural areas, you can go 30, 40 miles to get to a hospital, 100 miles to go to a hospital. That's normal. Now, take away the hospital 100 miles away, it's 200 miles. You don't want that. That's a real problem. There's limited resources for the providers. There's never enough health insurance. And as he said, there've been a lot of closures. It's been a real problem. And it's not just solvable by saying, all right, we're going to give them money. Because every rural hospital can't provide the same level of care. All right? What we need to do is, number one, look at it. We're trying to do this with the government now, talking about it. Not only in the cyber stuff and talking about regionalization, which was mentioned, and having big systems be helpers, perhaps, for the small systems, which required the government to finally say, yes, that's not going to be considered normant, that it's illegal for a system to help somebody else who isn't part of their system on cyber, yet at the same time, that small hospital may refer patients, let's say for tertiary care, let's say for a transplant even, to that bigger hospital. So that was kind of made it illegal before. They're finally realizing that, again, we should all work together. The other problem is we have to figure out how we can use technology differently than we do. Certainly telemedicine was widespread and used all during COVID. It's expanded, but we have to do more of it, all right? And we have to figure out how to leverage it. And it's not just telemedicine. It's not just straight telemedicine. It's telepsychiatry in emergency rooms, so that a rural hospital can get a psychiatrist to literally do a televisit in the emergency room, and so you know if it's safe to send that patient home or are they suicidal. We have to use that technology. Stroke centers have to use the technology in order to find out if the patient's having a stroke and what you're going to treat. We can use all those technologies. And the other area that rural really suffers from is how you're going to transport the patients. Our national EMS system is based a lot on voluntary ambulances, and there aren't enough of them. They're not funded enough, and a lot of them have closed. So now, not only do people have to go farther, there's less ambulances to take them, all right? And should we be using ambulances? Should we have a better helicopter system in these large areas? Should we have other things that are using technology? So we, eventually we'll get a drone and pick them up and ship them over. You do an Amazon package, we do it with people. So, we should be able to do that, but that's really kind of be the key for rural health, all right? And just another point, when the hospitals close in rural areas, they're often 15% of the income of that community, of the workforce. If those close, now not only does that community not have hospital care, they're a poorer community and less likely to survive. All right, so how's it going to be fixed? One way now, the government said that Microsoft and Google have offered free or discounted cybersecurity services to rural hospitals. That will help, and that is where the private industry should help. I still believe not only do you need that, but you need kind of big brothers where large health systems like mine and even large ones like HCA and Intermountain, Kaiser, and Extension, etc., go and help small rural areas and small hospitals, as well as help freestanding ambulatory surgery sites, which is there, popped up like mushrooms after a rainy week all over the country. We have to figure out how we're going to do this together. It can't be the government telling us they're going to fix it, and it can't be that we're going to expect the rural place, because they don't have the money. It was said before, you're the CEO of a 75-bed critical access hospital. You have a 20-year-old CAT scanner that breaks every other week, and you got a little bit of extra money. Do you spend it on cybersecurity, or do you buy a new CAT scan machine? It's a terrible dilemma to be in, all right? And we have to figure out a way we're not going to let that happen. And that happens in medium-sized hospitals too. You know, large health systems usually have enough capital, they can figure this out. But when you get down to medium already, you're running into a problem. Change healthcare. Rick Pollock, who's the head of American Hospital Association, says the most significant and consequential incident against the U.S. healthcare system in history. It truly was. It had a major impact. It resulted in backlog claims, which means that hospitals across the country lost basically, it's a total of about $1 billion a day in income. Now, most hospitals are not-for-profit and run on thin margins. And not-for-profit doesn't mean they don't make a margin. That margin is what buys the new CAT scan or puts in the new cybersecurity program or the new EHR. So that's a problem. Prior authorizations were denied. And people, if you have had a family member who needed, let's say, after the hospitalization, go for rehab or needed to go to a nursing home for a period of time, you don't have those prior authorizations. They sit in the hospital, or they have to go home, which is not a safe place for them. Patients couldn't fill prescriptions. That's a real horror show, and as we all know, if you have insurance for your prescriptions, if you have a 90-day prescription, not till day 90 or 89 can you get a refill on that prescription, all right? It's almost impossible. You have to kind of go there and beg them if you're going away or something and say, I can't, I'm leaving the country for a month, I need an extra month. And then you got to get authorization from the insurance company. Well, you couldn't get that, so people did that. And then my last one, 80% or 75% of the country has Epic. And it's great they built that book, what was it called now, Epic Castle or whatever it is. Well, what happens if Epic goes down in the cloud, all right, and as well as at hospitals? What happens if they kind of destroy the whole system, all right, which I guess is not beyond possibility. The records are gone. We'd be on paper for God knows how long, all right? How would we deal with that? And that's what we have to figure out. And it's really, this conference and others like it are really kind of critical. And then we get the regulatory issues. Senator Wyden got very upset with what happened to Change Health. And then he said, the standards should include requirements for organizations rebuild their IT infrastructure quickly, within 48 to 72 hours. So, Nate, would you able to do that in 48 to 72 hours?
Good luck.
I mean, and this is where we're trying to work in the healthcare sector with our government partners, explaining to them that those things are just not possible. We have to deal with reality. Reality, bad things are going to happen, and we have to be resilient, and I think that's a really good term, so that we can help deal with them. But we can't regulate our ways out of this. Because again, what happens when there are regulations? Checkbox, I did this, this, and this, I'm okay, and therefore I'm not going to get into trouble, all right? So, cyber has, specific risk points, increasing attacks, lack of transparency. Nate is an example of good transparency. Why? Because there's a fear of the regulatory. Are you going to get slapped by Joint Commission, slapped by CMS, all right? Are you going to get sued? So these are major, major problems. Everybody buys cyber insurance now, and it's like your homeowner's insurance, your car insurance, the cost keeps going up and it covers less, all right? And you put in cyber insurance, but, you can't prevent a flood, bankment goes down somewhere and your house gets, damaged, you had no control over that. Cyber insurance is something you may need, but we have control in some ways to hopefully make things better in terms of both the defense and things like that, and more importantly, our response to it, so we see that it has the least effect on us, all right? Workforce shortage in cybersecurity, this is a major issue, as you all know, all right? And people in large institutions, in large cities that are very attractive, have trouble finding people. Well, if you're out in the middle of nowhere in a 3,000 person town that has a small critical access hospital, not only can't you afford a real CISO, you probably have one IT person, or something like that. You certainly can't afford really all the cybersecurity stuff. So, and have somebody who knows how to run it. So this is a problem that we have to figure out. And finally, I just put out this last one, artificial intelligence. Healthcare is rushing to put artificial intelligence into everything. It is like the hot topic. Everybody's partnering with small startup companies, big companies, and all want to be able to say, we're using artificial intelligence for this or for that. And the concept of secure by design, meaning that it's going to be somewhat protected right from the beginning rather than slapping on patches later on and all that, is great. But people are not looking at it that way. And I really worry that, in the future, in the next couple of years, as we push the artificial intelligence game, because it will improve healthcare, there's no two ways about it. It's not the total answer. Last quote from my talk, from Dr. Wachter, who started the hospitalist program. He said any doctor that can be replaced by a computer should be. But, AI will help. It is no doubt, I've seen its use in certain specific areas, and it will expand. But AI is just as vulnerable. Both, it can be used as an offensive tool against us, all right, figure things out that will get around our defenses, or it itself can be attacked. And if the algorithm's wrong, we all know about the expression, bad data in, bad information out. It's the same type of thing. So we really need to think about that, and this is really something important on the test. So I'm going to stop at this point, take any questions, and Josh, I'll leave it to you to wrap up for lunch or whatever.
This was fascinating. I'm here representing a patient group today called the Light Collective. We're a bunch of patient activists, I guess I would say. I'm a transplant recipient, so I appreciate you mentioning the transplant world. So, for the last part of what you just said about the AI and the ML part, right? I have a million questions for you, and I'll focus on this one. Can you talk a little bit, expand on your point about what you mean people are really rushing the secure by design? They're not really thinking about it, or they're not really doing it. Can you expand on that a little bit, please? Because you hear people say, well, we're building it our own, right? We're doing it in-house, or all these things. So can you expand on that a little, please? Thanks.
Sure. So and I'm not an AI expert. I don't pretend to be a cyber expert. I may play a doctor on TV, but I don't play a cyber expert on TV. But basically, all this is based on the algorithms of what you put in, all right? How you design the thing. And yes, there's machine learning, and it learns from itself. Where does it learn from? What things did you tell it to read, so to speak? Which things did you tell it not to read, like Wikipedia maybe? So that, depends on the company and what they're thinking of when they design it, and how did they design it such that people can't go in and change the algorithms, all right? And again, it's no differently than, it could be a nation state, it could be somebody who has a grudge against something, some organization, or some person, or some hospital. And they go in, and they get in, they hack in, and they change the algorithms. And all of a sudden, instead of it telling you to do X, it tells the doctor to do Y. Now, we all hope that our providers, doctors, and nurses look at what's coming out of that and say, that doesn't make sense. And I will tell you my experience. I've had it where pumps were programmed wrong, and a nurse actually stopped the assembly line and said, I'm not, called the pharmacist twice. The pharmacy said, oh, everything's fine. They put it's in the library. Says it's not right, and actually stopped it and saved the patient's life. But I worry as we become more dependent on this, it's just natural human nature, that we'll pay less attention and things will slip through. So that's what I'm saying. Secure by design means it's, you know, it's gonna be updated all the time, it's monitored, and it's not easy to hack it, you know, it's, you know, maybe it doesn't come with its, you know, default username of admin and password one, you know. Maybe a system that you can't even turn the machine on until you first change the password and all that, and it has to be something that won't let you to change it to password 2, all right? And there's a lot more that, obviously I'm not an expert, but that's where I'm getting to. And it is a problem, because if the algorithm isn't right, it's worthless, quite frankly. And everybody's jumping on it. It's very, you know, it looks good, they get somebody from a hospital or health system to get on TV, say, oh yeah, we're using artificial intelligence for this, to do this and that. You know, right now for answering the phones, maybe it's good.
One more question?
Yeah, one more. Sorry.
Great talk, thank you very much. So I trained in emergency medicine in New Orleans and had the opportunity to work at multiple critical access hospitals around Louisiana. And I can kind of say from experience that for new technologies, new policies, things like that, even if you make the services free, there's still a very palpable level of skepticism in rural communities to really anything coming in. And I was just wondering if you could touch on how what strategies you have for kind of increasing buy-in from these communities for cybersecurity, knowing that cybersecurity is a pretty nebulous thing for the average individual.
So to get buy-in, again, you have to explain why you're doing it. So it's not, you know, getting people like Nate to come and talk would help. But I think that's why using the private sector to help, and you know, maybe not a Microsoft or Google all the time, but getting, let's say, they're a rural community, but they have a relationship that when they did need to send somebody for a transplant, let's say they're in some little town in, you know, in Alabama, they send them to the University of Alabama. Well, having University of Alabama work with them, all right? You know, and then they have to go there. It's not like, all right, you're gonna come to University of Alabama. They have to go there and talk to them, explain what they're doing, and support them through it, not just say, here's what you gotta do, and then walk away, you know, which a lot of consultants do. You gotta really go there and be around and have a constant, that's how you convince people to buy in. It's much like when we take over, you know, as North, when we bought small hospitals, we kind of did that, and understand, those people have to understand also the culture of the place they're working, because every hospital has its own culture. It's not that one's right and one's wrong, it's their own culture. They have to work together in that way. I think that's where the private sector will do better if it takes it on as a responsibility. And yes, even big health systems don't have a lot of money, don't have a lot of time, but the weakest link is the one that's gonna upset the whole thing. So we have to, you know, work with the people who are most vulnerable, because that's in our benefit as well.